Hi, Assalamu alaikum and good morning everyone. Thank you for visiting my channel again. Abdurrahim here with you. First of all, I'm really very much thankful to you guys. I can see the support you are giving to me and also the subscribers are increasing. I would really appreciate if you keep sharing it with the others. Okay. So let's come back to our topic. We are starting our new topic today, which is mitral stenosis. In this video, we are mainly going to know what is mitral stenosis, what are the main causes of mitral stenosis, and how mitral stenosis is going to affect the mitral valve, and then we will touch the mitral valve anatomy as well. Okay. So let's start our topic quickly. What is mitral stenosis? Mitral stenosis is actually the narrowing of the mitral valve. Okay, so when the mitral valve opens, the leaflet opens, it doesn't open properly. So there is a narrowing of the and the pathway of the mitral valve. So that's why we call it mitral stenosis. So it could be due to a lot of things which we will discuss in the next videos. But mainly you can keep in your mind that there is an obstruction across the mitral valve. Okay, there's a obstruction of the flow across the mitral valve. This is known as mitral stenosis when the mitral valve opens. So definitely it's in diastole. So if you put the color on the mitral valve in apical four-chamber view in a mitral stenosis patient, you will see that a flame is going from the mitral valve towards the LV. So this is typical with a mitral stenosis patient. Okay, so first, when you are going to describe the mitral stenosis, first you should know the anatomy of the mitral valve. I already described the mitral valve anatomy when we were reading the mitral regurgitation topic. I'll just go through it very quickly today. So mitral valve is actually consists of two leaflets. One is anterior leaflet, one is posterior. Anterior leaflet is bigger than the posterior leaflet. Then there are two annulus. One is anterior annulus where your anterior leaflet is attached, and one is posterior annulus where your posterior leaflet is attached. Then there are two commissures. One is anterolateral commissure and posteromedial commissure. These are the two commissures. They play very important role in mitral stenosis patients. Okay, so you can see in the picture where is your anterolateral and where is your posteromedial commissure. Then the next thing is the subvalvular apparatus. In subvalvular apparatus, you have the cords, you have the papillary muscles. So this is how a complete mitral valve structure is. Okay. So next we'll move on to our causes of the mitral stenosis. So if we talk about the main causes of mitral stenosis, the most common cause in the world is the rheumatic heart disease. Okay, you will see a lot of patients with mitral stenosis. The main cause will be rheumatic heart disease. Okay, so next could be the age-related or degeneration of the valve. Okay, you will see very calcified valves in this type of mitral stenosis. So this is called age-related or degenerative mitral valve. This is the second cause. Third could be the congenital. So if the patient is having a congenital issue, then it could be the congenital mitral stenosis. Then there are some diseases which can cause mitral stenosis. For example, SLE, carcinoid, infiltrative heart disease, and then there are some drug-induced mitral stenosis as well. Very rare. So these are the typical mitral stenosis causes. Okay. Now I will take you on to the presentation and I'll show you that how mitral valve is going to be affected, especially in rheumatic heart diseases patient. So once we talk about the effect of these causes on the mitral valve and how the mitral stenosis develop in different causes, I will definitely show you some pictures and some slides on the on the computer later on. But mainly in rheumatic disease, you need to understand the process of the mitral valve getting stenosed. Okay, so the thing is that in mitral stenosis, your posterior leaflet gets in rheumatic mitral stenosis, your posterior leaflet gets fixed. Both of your leaflets gets very much thickened. Okay, the anterior leaflet is quite much mobile, but the tip of the leaflet gets fixed. Okay, so you see somehow doming of the leaflets. Okay, so this is your posterior leaflet, this is your anterior leaflet. This area is mobile. Okay, this area is moving like this, but the tip is still there. Okay, so tip gives an appearance like this, hockey stick appearance. We call it hockey stick appearance. So whenever you have this hockey stick appearance, or we call it the doming of the mitral anterior leaflet, this is typical rheumatic valve. Okay, then your commissures gets fused. Okay, both the commissures gets fused. If your commissures are completely fused, then you are talking mostly about severe mitral stenosis. Okay, Then in the later stages, your subvalvular apparatus gets involved. The subvalvular apparatus gets very much thickened and shortened, and then the stenosis gets even worse. Okay, so this is how your rheumatic disease affects your mitral valve. So let's come on to the pictures. I will show you the same thing, how it looks like in the pictures. Okay, so here we are. First, I will explain you about the mitral, how the mitral valve looks like, or the anatomy of the mitral valve. So this is your left atrium, this is your mitral valve, and this is your left ventricle. This is the subvalvular apparatus of the mitral valve. These are the cords, and these are the papillary muscles. If we talk about the mitral valve itself, mitral valve consists of two leaflets, as I told you earlier. This is your anterior leaflet, this is your posterior leaflet. Anterior leaflet is attached with the anterior annulus, okay, and the posterior is attached with the posterior annulus, okay. And then you talk about the commissure. So this is your posteromedial commissure, and this is your anterolateral commissure. If you look at this image, this is your bigger leaflet, which is the anterior leaflet, and this is your posterior leaflet, okay. We came into the next, which is causes. I already explained you that the most common cause is the rheumatic one, then degenerative, then congenital, and then some diseases, including lupus or infiltrative disease, carcinoid, or drug induced. So these are the main causes of mitral stenosis. So what happens in rheumatic? What is the process of the rheumatic? As I told you earlier, first you need to look at the commissural fusion, then leaflet thickening, then caudal shortening and fusion, and then superimposed calcification. I will show you this in the next slide in the picture as well, that how you are going to see these things. Okay. Then what about the degenerative valves? You are going to see the annular calcification, and then rarely leaflet thickening and calcification. You will see that leaflet thickening mostly, actually these leaflets are thickened, but calcification you are going to see it rarely. But if the leaflets are also calcified alongside with your annular calcification, then it means the mitral stenosis is going to be quite severe. Okay. Then we move on to the next one, which is congenital. You can see it, you can get it from the name that it's a congenital abnormality. So you can have congenital mitral stenosis. Then these are the diseases which can cause mitral stenosis. Okay. So first we are going to talk about the shape of the rheumatic mitral valve. Okay. So this is how your rheumatic mitral valve looks like. Your posterior leaflet is fixed. Your anterior leaflet gives a classical hockey appearance. So whenever you are having this doming of the anterior leaflet, where your tip is fixed and your rest of the leaflet is mobile, so it gives an appearance of the hockey stick, because this tip is fixed here, but the rest of the leaflet moves. Okay, so it makes an appearance of a doming leaflet or a hockey shape. That's why we call it hockey shape appearance, or the doming of the anterior mitral leaflet. This is the classical appearance of the rheumatic mitral valve. So what happens in rheumatic mitral valve is that it converts the mitral, this tubular channel, into a funnel shaped orifice. Okay, if you look at this one, this looks like a tube. Okay, so it's an open mitral valve. You can't, like, it works like, behave like one chamber, LA and LV, and this is a tube. Okay, but if you get the mitral stenosis, then it changes tubular shape into a funnel shaped orifice. So this is the orifice, small orifice, funnel shape. So these changes are because of the rheumatic heart disease or rheumatic mitral valve. Okay, then the commissural fusion. This is very important. Okay, so this is the short axis of the mitral valve. Okay, and here are the commissures. This is one commissure, this is the other commissure. Okay, this one is known as anterolateral commissure, this one is the posteromedial commissure. You need to know these names very well, because once you are going to report your mitral stenosis, you need to mention about the commissures, whether the commissures are fused, they are split. Okay, if they are fused or one of them is fused, you need to write the name that, okay, anterolateral commissure is fused while the posteromedial is split. But if you see both the commissures are fused, it means you are talking about severe mitral stenosis. Okay, so again I will repeat the name. This is your anterolateral and this is your posteromedial commissure. Okay, keep in mind how I keep in my mind that once which is near to the lateral wall is known as anterolateral, once which is towards the posterior or inferior wall is known as posteromedial commissure. So these are the two commissures, and you always need to report which commissures is open and which is split. In this view, looks like both are fused and the orifice is quite small, so severe mitral stenosis. Okay, and then Leaflet thickening, you can assess the leaflet thickening in parasternal long axis. Some people also assess it in 4-chamber view as well, but I think mostly you can assess it well in parasternal long axis view. Okay. Next we come here. This is the M mode of the mitral valve. This is very important to know. Okay. In normal M mode, you will see this M pattern of the mitral valve opening, and then you see a closure line which goes straight. Okay. This is your EF slope. Okay. This is your EF slope. This mitral valve opens and then closes and then opens again and then goes straight. But what happens in mitral stenosis, if you come here, first thing you notice is this line is very thickened as compared to this line. This is a very thin line here. So this is a thin normal mitral valve. But if you look at this lining, this M mode of the mitral valve, this is very thickened leaflet. Okay. So the first thing we got is very thickened leaflet. The second thing is there is loss of EF slope. So once you are not having the EF slope, it means you are talking about mitral stenosis. And some people also say that if your EF slope is less than 10 mm, it means you are talking about severe mitral stenosis. So the M mode of the mitral valve is also very important to know. So how it looks like, this is how the mitral M mode looks like. Okay. TE we are not going to discuss, and this was the main causes and also their process and how it looks like. In the next vlog, we are going to discuss about the severity criteria or the quantification of the mitral stenosis. So please stay tuned and we will see you in the next vlog. Thank you. Bye-bye.